we'll get started. First up, I want to thank everyone for making some time out of their busy evening to join us tonight, and I want to thank our guests and all the other moderators for spending the time to interview and chat about these really interesting topics. So without further ado, welcome everyone. This is the AO Trauma North America Journal Club. Today, we're going to be talking about three particular papers on proximal humerus fractures, and we'll just kind of get into it pretty much right off the bat. So I'm Jason Strelzo. I'll help moderate the session. I'm from the University of Chicago. We have with us today Adrian Huang from University of British Columbia. We have Brianna Fram from Yale School of Medicine, and Dave Stockton from University of British Columbia as well, who will be joining us in a moment. They have interviewed our guest lecturers tonight, which I'm very thankful for them for joining us. To start off, we have Dr. Rami Al-Raba. He's from Inglewood Orthopedic Associates in New Jersey. We have Dr. Herman Johal, who will be joining us from McMaster University. And we have Dr. Patrick Curtin joining us all the way from University of Massachusetts. So hopefully you'll hear a little bit more about their papers, why they decided to study what they studied and what they found. And then we'll have a pretty open discussion around those papers. Here's some disclosure information. It's available also afterwards if it's of interest and of relevance. Let you just read some of the disclosure information here, but essentially everyone hopefully knows about AO North America, but it's a nonprofit surgical society. Obviously, we're dedicated to talking about patient care, musculoskeletal injuries. We don't endorse or talk about specific products or specific commercial entities. And what we're really talking about here is about a learning experience. We're not trying to go beyond that. If we're talking about equipment, it's really to demonstrate a technique or for a teaching purpose. Please, if you can mute yourself, we'll be using a Q&A feature, so please ask your questions in the Q&A box. We will either choose to answer those live during the discussion at the end of the papers, or we'll reply back to you so everyone can see the reply. We're going to try and get to all the questions, but please use the Q&A box. We really would like this to be an interactive session because it'll be substantially more interesting for you and for us, okay? And we will go from there. What we're going to do today, obviously, we're going to do a little welcome. Hopefully this is the most you'll hear me talking. Then we're going to go into our videos. So we'll have three videos back to back, and those will be discussing our three papers. Our first video, we're going to be talking about trends in surgical management of the proximal humerus fracture. The second paper, we'll be talking about reverse total shoulder and its use and cost effectiveness for proximal humerus fractures in the elderly. And then the third paper is going to be talking about mortality and morbidity of fragility proximal humerus fractures. So that's patients represented to a level 1 trauma center. Then we're going to open the floor. This is the time for everyone to please fill the Q&A box for questions, and then we'll have a short wrap up at the end. These go on a monthly basis, so if you enjoyed this and you enjoyed the content, please come back for our next one. And at the end, I'll sort of be promoting that next one for you, so stick around for that. And really, the idea is to talk about orthopedic trauma, some articles that we feel are really important to the literature. At the end of this session, we hope that you're going to understand a little bit of the practice management of proximal humerus fractures. We're going to discuss some of the changing philosophies. This is sort of like the moving sand beneath us for proximal humerus, and really makes it kind of an exciting topic because there is a lot of literature out there, and trying to make sense of that literature can be challenging. And then we're going to talk about some adjuvants to improve outcomes for patients with proximal humerus, and then some specific patient options. So without further ado, we'll get the first video up. And please, again, use the Q&A box. Please send in your questions so we can get to those for you.
So I'm here with Rami Al-Raba, one of the authors of a recent JBJS open access publication on trends in surgical treatment of proximal humerus fractures and analysis of postoperative complications over a decade in nearly 400,000 patients. So Rami, thanks for agreeing to be interviewed for this. Welcome to AO Trauma North America Journal Club. I guess just first, Rami, would you mind telling us just kind of who you are and where you were at when you did this study? Go ahead.
Sure, of course. Yeah, thank you so much for having me. So my name is Rami Al-Raba. I did residency training at Columbia, New York, and then I did fellowship training in sports and shoulder reconstruction at UCSF in San Francisco. And this paper here titled Trends in Surgical Treatment of Proximal Humeral Fractures and Analysis of Postoperative Complications over a decade in about 400,000 patients. I did this study while in fellowship at UCSF last year with the group there. We saw a lot of, the impetus for the study there. We saw a lot of proximal humerus fractures, and obviously they're treated by surgeons of different subspecialties. So trauma surgeons see them, general orthopedic surgeons see these injuries, as well as sports and shoulder trained surgeons. So we wanted to look at how these injuries were treated over the last decade in this country. So the basic summary of this, we looked at the Pearl Diver database, national database in the US, and we looked at the last 10 years from 2010 to 2019. Using diagnostic and procedural codes, we were able to identify patients with proximal humeral fractures over this past decade and to see how they were treated. Majority of them were treated non-operatively, but we wanted to look at the ones that did get surgery, what surgery they got. So we looked at reverse shoulder arthroplasty, open reduction internal fixation, and hemiarthroplasty. So we found the trends that over the last 10 years, open reduction internal fixation and hemiarthroplasty seem to downtrend, and treatment of proximal humeral shaft fractures with, proximal humeral fractures, not shaft fractures. Proximal humerus fractures were more commonly treated with reverse shoulders as time went on. The additional goal of this study was to kind of compare sort of the outcomes of reverse shoulder and open reduction internal fixation. So we did this by looking at complications, so the complication rate and reoperation rate of patients who got reverse shoulders versus the ones who got open reduction internal fixation. And we found that the complication rate is higher in ORIF patients, and also the reoperation rate is higher in ORIF patients. And we did this in patients who had at least 2 years of follow-up data in the database. In addition, we looked at emergency room visits and hospital readmission rates within 90 days after surgery. And we found that patients with reverse tend to have higher readmission rates. And we think that's probably related more so to their comorbidity index and other medical issues, because patients who tend to get the reverse are just older and sicker patients. So to summarize, reverse shoulder replacements is trending upwards for the treatment of proximal humerus fractures, for the surgical treatment of proximal humerus fractures. And also the reverse is associated with fewer complications, lower reoperation rate. However, there does seem to be a higher hospital readmission rate within 90 days after surgery.
Excellent. So could you tell us a little bit more about this Pearl Diver database?
So it's actually a national database for the whole US. It is mostly, from my understanding, it captures all the Medicare population. So generally all the elderly, but also some commercial insurance payers. But it is not limited to a state. It's just a national database, and within it they have subsets. So we used a subset of the upper extremity database subset. So it's patients who had diagnostic codes related to the upper extremity, as well as procedural or CPT codes, or had surgery with regards to the upper extremity.
Great. So, yeah, I guess the kind of the motivation for the question is, what's the potential for attrition within that database? Like, if someone has a complication, are they almost always going to be captured, or is there a possibility, even if they switch providers or something like that, can they drop off?
Yes, that is one of the limitations in the study. They could certainly drop off, but to minimize that, that's why for the second part of the study, looking at complications and reoperations, we only chose patients who had active data for 2 years. So they basically were seen at 2-year follow-up. But that is certainly a potential limitation for sure.
Great. Yeah, no, that's I think one of the very powerful things about large databases like that, and just being able to provide commentary and give a pretty accurate snapshot probably of what's actually happening. So yeah, well done for doing that for this fracture. And another question I'm wondering is, in your population, what factors do you think were driving which surgery got performed? Do you think patients, depending on where they present, have an equal opportunity to potentially be treated with ORIF or a reverse total shoulder? Or what kind of factors do you think are driving those treatment decisions?
Yeah, that's a great question, and it sort of alludes to what we were talking about before. Certainly, any surgeon looks at basically the bone quality, the fracture itself, and the patient's age. However, all that being equal, patient presenting to certain hospitals or certain systems or certain geographical area, and depending on who's on call. So I know, trauma trained surgeons like yourself may be more willing to ORIF, whereas in my hands, for example, an elderly patient with a 4-part proximal humerus fracture, I would feel definitely more comfortable doing a reverse. And that's, that speaks to our training. You're trauma trained, and I was more shoulder reconstruction and sports trained. And so that definitely plays a factor. We weren't able to obviously account for that in this study. But it's interesting that, all things being equal, looking at general trends, and this is, 400,000 patients. So with all things being equal, it does look like the trends are increasing for the reverse replacement. For me, in my hands, I would certainly feel more comfortable and getting more of a stable construct doing a reverse for someone over the age of 65, 70 with a 4-part proximal humerus fracture.
Great. Yeah, no, it's a phenomenally interesting, I think, part of the treatment of this fracture is kind of the overlap between some subspecialties within orthopedics, and kind of how that's playing out, I think, is really kind of well captured as a summary in your paper. And another thing that you mentioned in the discussion is that, perhaps the complications experienced in the reverse group are more severe. Do you think that kind of tempers surgeons' willingness to perform reverse? It still, in the end, it was only kind of being performed in about 5% of proximal humerus fractures, kind of from the more recent years. But how does that kind of could you kind of expand a little bit more on the complication profile between ORIF and the reverse group?
Sure. I mean, the most common complication was stiffness in both cohorts, but the reverse replacement, usually when you do an ORIF, the first 2 years, once it heals, you have a low risk of infection in the future. But when you implant, a joint, you have an infection risk basically for the rest of your life. And so that's where that more the more invasive explant and doing an antibiotic spacer with the reverse comes in. So it is a potential risk. I think it goes back to the surgeon's training. I think if you as a surgeon are not comfortable dealing with all the potential complications of that surgery, then probably the reverse should be done by somebody who is comfortable doing a reoperation and a potential explant and revision of the shoulder. In terms of deterring surgeons for doing a reverse, you know, I'm not so sure. It's still it's a risk. It's relatively low. But there have been some more recent studies, especially out of core, that show even when you compare the cost-effective analysis of treating these fractures, whether it be ORIF or reverse still still was more cost-effective. So in the long run, when they look at multiple factors, not just the surgery itself, but time off of work, et cetera, the reverse was still more cost effective. So I think at the end of the day, the surgeon should be sort of comfortable dealing with all potential complications. But I wouldn't say it's a deterrent, because if you were to do an ORIF first, there's been multiple studies showing if you end up doing a reverse in a revision setting, they don't do as well as if you had done it as the index procedure. And this has been replicated, for hips as well. So obviously as surgeons, we want to try to do one best operation from the get-go.
And so another question, kind of getting towards the summary, is that clearly proximal humerus fractures are an area, a particular fracture where really high quality evidence is lacking. And yet clearly we see these shifts in management trends over time. So what are your thoughts on what's driving these changes?
I think that's a great question. I think part of it is industry, I would have to say, with these implants evolving, and with surgeon education and being more comfortable with these implants. I think part of it is industry, but also I really think it's the technical, I want to say, ease of operation with reverse as opposed to ORIF. Certainly, it could be just I'm biased because of my training. For me, I think a reverse is technically easier than an ORIF. And if it has better PROs and better patient outcomes, then it's a win-win. Whereas trying to reduce all parts of the fracture and be biologically friendly and being able to achieve, adequate fixation. So I think part of it is industry. Part of it is surgeon education with these new implants. And I think, in the future, I think we're only going to see these reverses become more common, because as this kind of became FDA approved in the US in 2005, but really it wasn't starting to get implanted until the 2010s in higher frequency. And now there's more and more studies coming out that even for elective surgeries, the reverse is becoming more popular than an anatomic, for example. So I think those two things, the industry and technical ease of implantation, I think are some big driving factors.
Perfect. Great. Well, thanks so much for coming on the AO Trauma North America Journal Club. Anything final to say before we sign off?
No, I'm excited for the future and to see more studies come out about proximal humerus fractures, I think we will continue to see an increasing trend of reverse. But we'll see what happens. It's our generation, you and I, that's going to have to deal with all the complications for reverse. We already are seeing some, but I think our generation of surgeons is going to see a lot more, periprosthetic fractures, some some stress fractures, and some complications of reverse, and it'll be up to us to kind of see how we can treat those well. So I'm looking forward for the future.
Absolutely. Thanks, Rami.
Welcome to the AO Journal Club on Proximal Humerus Fractures. My name is Dr. Adrian Huang. I am an assistant professor at the University of British Columbia in Vancouver, Canada. And I am very pleased to have with us today Dr. Herman Johal. He is an assistant professor at McMaster University, which is in Hamilton, Ontario, Canada. And he is here to talk about his study, the cost-utility analysis of treatment strategies for complex proximal humerus fracture in older adults. Welcome, Dr. Johal.
Great, Adrian, thanks for having me. Thanks for the invitation to participate.
It's wonderful having you here. And from a very personal perspective, my subspecialty is upper limb. Thank you for doing this study, because I think this was a very important study to have, where you actually have one that compares non-operative intervention to all the surgical treatment strategies all in one studies.
It was great to be part of this, the team that investigated this question. And I really do have to give the credit to the entire team that collaborated to put this initiative forward, and especially San Calic, our lead author there, one of our second-year residents at McMaster, who really, I would say, learned a lot through this analysis, and really appreciated, as we all did, the challenges in comparing not just two interventions, but broadening that scope up to all of the possible interventions.
You're saying too that cost utility analysis and health and economic analysis is also just an interest of yours. Is that correct?
Absolutely, and I really gained an appreciation for the role, that cost analyses play in our decision making, but also how they sit into the overall spectrum of value that patients and providers have to decide upon when coming to treatment decisions. So, cost analyses is just one tool in our toolbox, but certainly a critical one.
So why don't we just dive in, and why don't you tell us about your study?
Well, great. And again, I have to give the credit to our lead author, Hassan, who's prepared some of these slides, provide a good summary of the study here. So we performed a cost analysis, cost utility analysis, looking at treatment strategies for proximal humerus fractures in older adults. And as we discussed, this is a complex issue involving the upper extremity in geriatric patients, specifically with low energy injuries that may result in very high energy fracture patterns, and also high energy injuries as well that pose treatment challenges when you have 3 to 4 part proximal humerus fractures. But across that spectrum of patients, we've explored many treatment strategies, including non-operative management, open reduction, internal fixation, hemiarthroplasty, and more recently, reverse total shoulder arthroplasties. And lots of summaries have come out, recent reviews to help summarize the clinical evidence that has shown there may be some high quality evidence that directs, that demonstrates that there are favorable outcomes for reverse total shoulder arthroplasty. However, it's important to note that the cost of reverse total shoulder is up to 4 times that of an open reduction internal fixation. And so it really poses the question, should we pursue this high cost but potentially high value? So we have to weigh the benefit to the cost, and the cost utility analysis is an excellent tool that allows us to do that. And that really allowed us to pursue the objective where we wanted to assess the cost effectiveness of a reverse total shoulder arthroplasty relative to conservative management, open reduction, internal fixation, and hemiarthroplasty. And so to do this, because there's no real study that compares all of these, there's no clinical evidence that we could directly apply, we modeled it, and there's various ways you can model. We chose a decision tree to model the 1 and 2 year outcomes, so the more acute outcomes, and then extended that using a Markov model, which really took this patient population and followed them for the rest of their years, essentially, that they were living with this treatment decision. And it was constructed to evaluate those treatment outcomes we were able to assess the change in costs, or the difference in costs, as well as the difference in quality adjusted life years, which is the key functional outcome. We're looking at in a patient population of 75 years old and older, primarily female, and looking at a 1-2 year as well as a lifetime time horizon. We used our own Canadian healthcare system to provide the single payer perspective, and we used a willingness to pay ratio, or essentially a threshold value of $50,000 Canadian per quality adjusted life year gain, which is a commonly used threshold. And we used different parameters to model the health utility outcomes, which were primarily evidence that came from level 1 RCTs. For costing, we used our own regional databases and local costs to represent costs of similar Canadian healthcare systems. And then we used the transition probabilities. So the transition probabilities essentially reflect the chance of something happening, whether it's a reoperation, an infection, using mostly evidence from level 1 RCTs. And where there wasn't available evidence, we used an expert panel to provide an opinion. So these are our essential models that we constructed. On your left, you see the decision tree model used for the 1 and 2 year outcomes, where we could essentially model each outcome and the potential subsequent outcomes over a 1 and 2 year period. Subsequently, those patients fed into a lifetime model using very commonly available Canadian data at the population level, be able to model expected life years and the functional probabilities and declines over that restful lifetime to get an overall change in costs each year and the subsequent change in qualities for each of these pathways to get those incremental cost utility ratios. So these are the results. You'd expect the non-operative management treatment decision to be the least costly, but there's still a cost associated with that, primarily from initial treatment and then the subsequent risks of that patient needing some sort of operative management if, say, there was a complication, and also subsequent days in hospital that were associated with that. As you look at each of the subsequent treatments, you can see that an open reduction tunnel fixation is about the same price as a hemiarthroplasty, but the outcomes were drastically different. And the most expensive option, which was not that much different when you consider the costs of those other operative options, were the reverse total shoulder. And you can see that actually had the largest functional improvement. And so when we compare each of those values, what you see is comparing reverse total shoulder arthroplasty to the other options. The difference in cost over quality adjusted life years was roughly $7,500, which is well under what we consider for the threshold, compared to hemiarthroplasty option, which did have some improvement, but not enough to justify the increased costs. And then an open reduction fixation is what we call dominated or not effective relative to the other options, given the average impact and functional improvement you'd expect. Those are outcomes that we got using the parameters you fed in from level 1 RCTs as well as expert opinion, but we acknowledge there's some estimate and a confidence interval around each of these parameters. So we were able to model that using sensitivity analysis, where we changed one of the parameters and reran the models, and that's where we were able to get some benchmarks and thresholds around our data. We used the base case value, expecting the probability of revision versus total shoulders in the first 2 years to be around 2%. That revision rate has to be as high as 11% for a hemiarthroplasty to be considered a potentially better option. Cost is an important one to discuss, and we used a rough base case value of about $20,000, and in certain settings, the clinical settings, that number is going to vary. So that the treatment cost would have to be upwards of $65,000 Canadian, which in our model currently you wouldn't see. And then you look at the expected utility improvement, and we'd have to expect the improvement with the hemiarthroplasty or another arthroplasty option to be over 0.9 out of 1, which is a really high improvement. And similarly, the well after reverse total shoulder would have to be less than 0.778. And so, in considering the average effect in the literature that we were able to input into our models, as well as some expert opinion, it appears that reverse total shoulder arthroplasty is the most cost-effective strategy in the management of these patients and older adults who need an intervention. And a sensitivity analysis demonstrated that there may be some changes in situations that this may not be the case, but those are increasingly impossible in the clinical environment that we work in today. Obviously, there's some strengths limitations, and especially a lot of limitations, I would say, that go into this modeling where we have gaps in the literature and we have to use estimates around those gaps. And given that we used our Canadian healthcare setting, you have to consider where you're going to apply this evidence. But that's the purpose of some of these sensitivity analysis, is to give the readers a chance to go through and decide how directly they're going to apply this evidence and how much it applies to their clinical setting. But ultimately, I think more clinical evidence, more high-level clinical evidence is needed to inform some of these gaps, and that would improve the conclusions that we would be able to put forth for you guys in the conference with those conclusions as well.
Thank you. That's an amazing breakdown. A couple of questions for you, and hopefully maybe some things that'll springboard some discussion. But this is a modeled study, and in your study also, you kind of talked about confidence intervals, and that reverse is 66% likely to be the most cost effective. And so does that take in all of these modelings and all of these confidence intervals that you're talking about then?
Yeah, and that's sort of the confidence with which we can put forth those decisions. And then the more high-level evidence that goes into these estimates, the tighter those confidence intervals get around those parameters. So we put, we can only, as we run a model, we can only really run it with one number at a time. But
yeah,
if you run the model over and over again, you can sample across that confidence interval. And if we can narrow that confidence interval, then potentially we can have a higher probability of that being the case, if a reverse total shoulder arthroplasty being the most cost-effective option. 66% of the time takes into account the uncertainty with those estimates that go into it. And that being said, that's anytime you apply clinical evidence, you have to consider your own setting, and that's where you have to consider what's best in your hands. And for some surgeons, they might be at various ends of that spectrum with those confidence interval, with their outcomes as they can expect.
So that's a great point. So that brings up two questions. First is, you gave some examples of when your assumptions would maybe not be valid. However, it seems like the instances that you brought up are not something that would realistically happen in real life. For example, revision rates of a reverse being 11%, or non-operative fractures having a quality of 0.93, which, as you mentioned, it was actually more than their pre-injury state. So even though it's, quote, only 66% certain, I mean, the times when it wouldn't be seem quite out of reach.
Well, and I think there's two ways to think about the sensitivity analysis we performed, and that probability or likelihood of this being a cost-effective intervention. And so that one is that confidence interval I discussed, where based on the evidence, the range of values and what we'd expect in terms of 25% or X number of percent variations around our estimates. That's what goes into the probability of an intervention being cost effective to a specific level of confidence or probability. But then, as we got those outcomes, we did another type of sensitivity analysis, is you essentially just pick an important parameter and change it to the extent that that number would have to change for the conclusion to switch. And so that's some of these numbers that you see are from an analysis of that nature, where it might be something that isn't necessarily clinically plausible, but if you were going to say have, for instance, let's look at a hemiarthroplasty having to bring the outcome to 0.9 out of 1, which is very high, and as you mentioned, higher than the pre-injury level. Well, maybe not a hemiarthroplasty specifically, but if you were going to be looking at something that you would maybe consider even more cost effective than a reverse total shoulder arthroplasty, it would have to be effective to that extent. It is another way you could think about how to apply that evidence. But is a hemiarthroplasty ever going to reach that threshold? Probably not with their current technology, but I think that sort of speaks to how a reverse total shoulder might function. I would say they perform well in the skilled hands to apply them, and then that's the other way you really need to consider the conclusions of this study is what how does something function in my hands, and maybe with an arthroplasty in the arthroplasty options list. In certain people's hands, maybe a hemiarthroplasty might not perform to 0.9%, but a reverse total shoulder also might not perform to the thresholds that we applied in the study.
I guess the next question then is, does proximal humerus fracture now become more of a subspecialized treatment, especially the 3 and 4 parts? Because arguably, most of us are trained to do a shoulder open arch internal fixation, but not everyone is trained to do either a hemi or a reverse. So is this something that maybe we should be getting more specialized to kind of get the outcomes that are available or that are, I guess, required for this?
Well, I think that's a great question, and I think it pulls into the fact that you need to consider where the evidence comes from and the data. There's the real world data that we have. There's the expert opinion, but then also those real world studies. Part of the challenges with applying that evidence is there's also limitations in how those studies were done. So, for instance, if you consider something like Proffer, which was very high quality, high level RCT, where we did have to, and some of those estimates were informed by the Proffer study. That was a study looking at op versus non-op proximal humerus fractures. Conclusion was non-op is better, performs better than operative. However, the patient population, some that excluded patients who would be getting an operation in anybody's hands. So then, now that you have to consider these other options that we present here, where if you're going to be operating on that patient, which of these options are you going to apply? On the average effect across those options, it seems like a reverse total shoulder would be better. But there are instances, say in emergency situations, open fractures, other situations, maybe that resource isn't available to you for a variety of reasons. That you shouldn't feel that you shouldn't be doing an open reduction internal fixation, but just if you can, maybe for that patient who needs an operation, then if providing access to a reverse total shoulder arthroplasty may be something that's worth being part of the discussion at least. I think this is, as complex as this study would be in terms of the methods and the analysis. I think it's always important to consider this is only one part of the one piece of the puzzle when we're making these treatment decisions. And there may be situations where I can apply this and get that patient to the right person's hands to get that reverse total shoulder. But if I can't reliably perform that operation to I would say the parameters that we lay out in an analysis like this, then you would still need to consider those other treatment operations.
What is, I guess, the one takeaway that you'd want people to take away from from this paper?
I think an important contribution of this paper to the evidence is that we need to look at these high resource treatment options in a different perspective than I think the traditional way that a lot of administrators and healthcare systems make these decisions. And then oftentimes these are very siloed decisions. These are very, single focused budgets that lead to, I would say, in a single payer healthcare system, providing some restriction into, say, the application of reverse total shoulder. And I think what this does is it draws that treatment decision away from that single silo. And when you're considering a cost analysis or any sort of, I would say, value literature, you want to be able to look at it and bring that to the decision maker subsequently by connecting those silos. And so, not just, I get the reverse total shoulder is a very high ticket item, but there's less reoperations, and for that patient there's important functional improvement that might lead them to being discharged earlier, or fewer length of stay days, or lower lengths of stay, and other complications that these decision makers sometimes lose perspective of. So I think an important takeaway is arguing for the application of this literature across the different silos. I think that would be affected by it.
What are the motivations for doing this study?
Yeah, so I during my research year, I'm the research resident at my home program at UMass, it felt to me like a lot of the fragility fractures we were seeing weren't doing as well as we had thought they might. Like, I think in publications, like, we kind of understand that geriatric hip fractures have a high mortality rate and benefit from all these pathways and resources and osteoporotic care and co-management. But it felt like, as a consult resident and junior resident, that we were seeing other types of fractures that were kind of these fragility fractures, but because they generally were treated non-operatively, weren't really falling to our purview, but also in kind of chart review weren't doing great. So that was kind of the prompt to just like look further. And in kind of my research lit review looking at proximal humerus fractures, there wasn't as much out there on kind of how these patients do and their morbidity and mortality. And so it was kind of the first step into looking at some of these fragility fractures and trying to figure out what we can do to kind of hopefully start improving their outcomes.
Take us through a little bit sort of the design of the study, because it was a retrospective chart review, right?
Yeah, so the design was to look at all of our institutional data at proximal humerus fractures, specifically the fragility fractures. So what those patients more specifically, and then tried to set up certain standard parameters and risk factors that we thought were going to be important. So look at their handedness relative to their injury, their side of their injury, whether they got surgery or not, how sick they were, of which we used the Charlson Comorbidity Index as one of the main driving factors. So pulling all of that as in addition to a few other things, as well as also primarily their mortality. So for anybody, even if we were pretty sure somebody had passed, we would still mark them as alive so that we weren't overinflating our death rate. So even if somebody was like leaving CMO, terminal extubation and going home, if we didn't have that in the chart and they didn't have an obituary, we would mark them as alive so that we weren't incorrectly elevating our mortality numbers.
Did you collect information in advance on patients' assistive device use for ambulation? And if
Yeah,
so,
yeah, we did. So the assist devices is part of our protocol it is for a lot of orthopedists, part of our consult notes and part of something we ask about for mobility. So the good news is that what was in pretty much everybody's note somewhere if they made contact with us. We did one thing that we had hoped we could have recorded and weren't able to due to the limitations of the study is, their advancement and seeing, if, post-injury, how well they bounce back and their escalation of getting back to, they were, let's say, a community ambulator and then went down to a cane or walker and then went back, versus if they kind of stayed at that lower threshold, if that meant anything. We were able to get that information, but we didn't publish on it just based on the fact that we couldn't get enough reliable information for that to be made available, unfortunately.
were people being indicated for surgical stabilization or surgical treatment of their proximal humerus fracture based on need for an assistive device, just based on your knowledge about the cohort?
Yeah, I would say anecdotally and kind of looking through our numbers, we had 379 patients ultimately in our cohort. The whole proximal humerus or upper extremity fracture stabilization to help aid in mobilization that I know we do in trauma sometimes was a little less applicable in this cohort compared to some of the polytraumas that we do that for. There was a couple patients that did get surgery, and statistically they were found it was the only protective factor, which really was more of an indication that these were a healthier group of patients that were getting elected to proceed with surgical fixation or arthroplasty. But I think the driving factor with that is that some of these patients were just too frail to get surgery, or even the ones that might have been operative, they they still were unsafe to get surgery.
Sort of to summarize, it looks like the only treatment characteristic, the only modifiable factor you guys found associated with a decreased risk of mortality and an association was surgical fixation or some sort of operative treatment of the fracture. All the other things were non-modifiable. Is that an accurate statement?
Yeah, and that we were curious to see what else might have played in. I think some of our hypotheses from some of the people on the project were that there might be handedness, so that if it was the same the contralateral side and they still had a good hand, that might show increased survivability or some mortality protection because they still have the ability to kind of better take care of themselves with their dominant hand. We had a similar model project that we had worked on that's currently submitted for publication, looking at LC1 pelvis type injuries, and again, fragility fracture type patients, that the protective factor for them was actually follow up with a primary care physician and being in close contact with their medical provider. And so that was found to be protective for them. And it seemed to be because they were able to better address some of the other things that are going on that are causing them to fall. So their neuropathy from their diabetes, their COPD, and their lack of oxygen, fall risks where they're tripping on throw rugs at home or their O2 tubing, like these things that ultimately are leading to their initial presentation. And we were trending that way with the proximal humerus fractures, but we either had, maybe we don't see some of their follow-ups in their medical or primary care docs in our system and are not capturing that correctly, or in this case, it's just trending towards being significant, but just isn't, and we're underpowered, or potentially it's not significant at all. But that was definitely something that we had hypothesized going in, but did not prove to be true in this patient cohort or in our patient population.
With regards to this study, is it going to change anything you're going to do treatment wise? And we'll start with that question. Is it going to change anything you're going to do treatment wise the next time you see a geriatric proximal humerus fracture?
With now, my philosophy's changed quite a bit, and sometimes this is their first interaction on osteoporotic care. That's something that hasn't been raised as a discussion with them, either for poor access to their primary care, or maybe this is just their first fracture. So talking to them about whether or not they've pursued some sort of osteoporotic care or workup is something that I'll now talk about. And a lot of these patients, at least in our group, will say kind of no. So we're getting them tied in for that. I think another change has been, instead of also kind of downplaying, well, the good news is no surgery. Sometimes this is not that big of a deal. You just need time to heal. Also saying, this can be associated with a high complication rate over the next couple of months. And sometimes that's because of other things going on, other medical problems, or sometimes it's because you fall once, you can fall again, and using that to kind of dig a little deeper to make sure that even if we're not the ones directly managing it, that they're tied in to see their PCP. Great. I think long-term and institutionally, it would be nice if we have a good hip pathway, trying to work on connecting people with resources if they come in with a geriatric hip fracture, both in-house with geriatric co-management, but then also post-op, making sure if they are applicable, getting them into endo and osteoporotic care. Really, though, the sooner the better, and the amount of prevention we can do, the better. And I think that some of these patients are still on the later end of that timeline, but it's still earlier than some of the hip fracture patients.
Yeah, it's all speaking to that quote unquote own the bone initiative or concept that when someone presents with their first osteoporotic fracture, that just because they're seeing an orthopedic surgeon, they should be plugged into a medical provider who can help, initiate osteoporosis workup and management to try to prevent loss of future bone density, right?
Yeah.
And so it sounds like you're interpreting this as this paper just shows that proximal humerus fractures, geriatric low energy ones, are akin to hip fractures in that they're really a sign of overall frailty, that someone's balance is starting to get poor, that maybe they're not doing so well taking care of themselves at home, and that they may need more directed medical and living situation interventions, and that surgery probably isn't going to change these, based on your interpretation of the results, their outcome, even if they're a pre-injury assisted ambulator and we can stabilize your proximal humerus or do a reverse total shoulder and let you use it right away. But that's not really what's happening here. What do you think the next step is in terms of the next study, the next question, the next potential intervention?
Yeah, so I think that unfortunately, like you said, it would be great if we could just operate on all these and they would do better. But looking at our data more closely, clearly the operative patients had far lower Charleston comorbidity indexes, and it wasn't that they were doing better because they had mobilization. They were doing better because they were baseline healthier individuals that we were operating on. And so kind of the next steps is this project was hopefully more of a pilot study and a good marker to just say, these patients don't always do well. Here's some numbers to kind of proof of concept that now how can we do better? So I think that the how can we do better aspect of this would be looking at some of these patients prospectively, trying to intervene with them earlier. So trying to get a pathway set up to get them into endo referrals or into our own clinics for own the bone, depending on institutionally how things work at various places, but trying to intervene on osteoporotic care for some of these patients and counseling on fall prevention and getting them tied into both us and some form of PCP or geriatrician, and then seeing how does that affect their mobility, their morbidity, and their mortality in a prospective, just looking at them and then kind of comparing that to this. Be nice to do it that way as opposed to like a randomized, group prospectively, because at this point we sort of know that they're not getting enough. So it would be nice to use these numbers as a benchmark and then see what we can do to improve, instead of withholding some of that information from patients going forward. So some of it's definitely research driven, but I think some of it's just kind of QI and quality pathway improvement at some of these institutions would be sort of the next steps using this kind of pilot study numbers and information.
Yeah, excellent. To your point about getting people hooked up with a PCP or a geriatrician, sometimes I think that having one home physical therapy or occupational therapy visit for someone to actually go through and say, this is a throw rug, this is a trip hazard, and remove things and put a piece of neon tape on the step between the living room and the kitchen and actually physically reduce the fall risk, could work wonders. And if you had follow-up in this cohort, we're able to see how many people had a additional fragility fracture within a year, which I don't think you reported in the paper. I don't know if you could see that information. Then you could do that comparative study with an intervention cohort and say,
yeah, no, I totally agree. And I think that we could see that for some patients, not enough to reliably report it, but I mean, there were certainly people who came back with a couple with hip fractures, some with some vertebral body compression fractures, just other kind of standard osteoporotic fractures that, clearly you're at risk for one, you're at risk for more. So getting intervention on would be ideal for sure.
Any other key takeaways, things you'd sort of like to say for the listeners about the topic, about the study?
Yeah, I think that no matter what people have and patients have, the one thing that kind of kept coming back following these patients and with other patients like this are that this is such a great intervention and touch point, because patients are able to do something and then they can't, or something hurts and they want to not have that happen again. And so think part of the reason that's why we have such good follow-up in some of our orthopedic clinics, and then these patients aren't necessarily going to their PCP, is they're like, well, my arm hurts, so I want to go to the doctor that's the arm doctor that's taking care of this. And so us advocating for them to see a PCP or prevent fall risks or work on their other medical comorbidities, they remember that because they're so hyper focused on the fact that they're here for this, and so anything they can do would help. So if we kind of help tie that together, I think that will make a big difference as well.
Awesome. So those are the 3 videos. Hopefully that's stimulated some questions for everyone. I know there's already some questions in the chat, and I see a couple of questions in there now. So if you have additional questions, please throw them in the Q&A and we're going to get to them. I'll probably start with the Q&A questions, just so we're answering those right off the bat, because I think we've got a little bit of time. So the first one that came through was a really interesting one, which was from Robert. So thanks, Robert, for sending that in. And this question was really longevity of reverse total shoulder for fracture versus degenerative OA. And I think both myself and Brianna answered that. But just for those that didn't get a chance to read the article, there's a couple of recent meta-analyses suggesting that the outcomes of reverse for fracture are not the same and have a slightly different risk profile compared to our sort of more quote-unquote elective or rotator cuff type degenerative reverse. I don't know if anyone on the panel has any other thoughts about the data out there about trauma versus elective reverse shoulder.
I think that's accurate, and based on some of the more recent literature, as you mentioned, we did try to model some of that into our cost analysis, and did account for the fact that although elective reverse total shoulders do have this great track record of these functional outcomes, we can't quite expect that same result in the trauma population. So that's a real phenomenon. Where we did have some gaps in our models and tried to adapt some data from reverses, we did try to in the elective population to discount for that very same reason. And there's real world literature that supports that.
Yeah, that's great. I think that one of the second question that came up from that, and Robert asked sort of a little bit of a follow-up, and I think I'm kind of interested in this, which is, what do you think the role is for, because there's some expanding data to suggest, patients who have we're going to call it a secondary reverse total shoulder. So patient who's had a trial of non-op or have had a primary ORIF attempt and then have gone on to subsequent reverse. Some of the recent data suggests that maybe those outcomes are not as poor as maybe the historic data suggested. And so I'd be interested to hear kind of across the panel what people think that the role is for that, particularly in sort of the cost analysis, and then looking at the differences between, Rami, for your study, for instance, looking at complication profiles.
Yeah, so I guess I'll start us off and say, I think it's very interesting because I think it gives you a new toolbox or tool. So to say that, for example, like you're saying, some new data suggests that the secondary, especially if importantly, that delayed reverse. So basically like a one where they had a fracture and you try non-operative, as you said, may not be as bad as we thought it was, I think is really important, right? Because it gives us the opportunity for a lot of these patients to treat them non-operatively, the patients who we've identified as being a little more frail, a little more perhaps high-risk surgery compared to a primary. And then if they fail, then you still have something in your toolbox that actually still benefits them quite a lot. As an extension of that, I don't have any evidence for this, but we do a lot of them. So it's my personal kind of opinion that a lot of these outcomes do have to do with your experience doing them, because as everyone on the panel probably knows, everyone who does them knows that doing a primary reverse shoulder replacement is a vastly different surgery than doing one for fracture. And so I do believe that a significant portion of the outcomes of reverses being quote unquote worse is because of things like, continued tuberosity non-union or, essentially a deficient, like a posterior cuff, right? So, I think that if you have somebody who is trained to do a lot of them, especially in a perhaps even delayed fracture setting, I think that's very important, because even once you get 3 or 4 weeks out and the callus sets in, you have to spend a lot of time kind of dissecting out and kind of isolating the GT and the LT. I think that's very important. And then second, and it kind of leads you to another question, well, then how do you repair those, and how do you ensure that you kind of get good tuberosity healing? I personally still really believe in that, in terms of the outcomes. And there's a big difference, as you know, even in the primary setting, for how people manage the cuff, even in a primary reverse, in terms of some people let the tuberosities or the cuff just fly, which I think is a detriment personally.
Yeah, I think that it becomes really interesting to think about the algorithms and how you're going to apply a lot of this evidence that we discussed across all of these papers, really. And as a trauma surgeon and someone who likes fixing things, it's hard for me to say with this fracture that comes in, I'm going to maybe put this one on ice and pass to my arthroplasty colleague, or not do the operative intervention that's best maybe in my hands, but actually, now that I'm not going to operate on this patient, how long do I have to get this patient to my arthroplasty colleague, essentially, is what the question becomes. And we've looked at the evidence, but we've also looked at different options within our group. In some settings, you can get this patient to an arthroplasty surgeon within a week. In some places, it might take a few weeks, might take even, now, do we have 6 weeks? Do we have 3 months? How long do we have? What's that threshold? And as we're trying to, as we went through different algorithms and in the previous literature, as you mentioned, we saw that if you wait, a longer time, that secondary operation has become a lot more complex. Maybe you can't expect that same impact, that same result. I think as we're getting more surgeons out there that are getting better with this new technology, that threshold is changing, and that's what you're seeing with that. The more up-to-date literature is potentially implying that you can wait, 6 weeks or maybe a few months to get that patient into the right person's hands. I think it just involves informed decision making, and when that patient comes to your fracture clinic, comes to your emerge department, it's not necessarily saying, we have this option, we have to do it within this time frame. Presenting, getting that patient to have a good discussion with surgeons who can give those options, but also provide numbers around those options is key. For most fractures, we say we have, 1 to 2 weeks if we talk about ankles, wrists, some the common fractures you see, not hip fractures, but some of these more common upper, same day home kind of fractures that were essentially proximal humerus, I would include with that patient population. Have that time frame, and then if the patient chooses to go through this, then we can decide a secondary time period there. But I think that what we thought was a detrimental time period to wait is getting shorter, but we just need to provide these options is the message, and provide them to surgeons who can provide those options.
Yeah, I just want to chime in. Sorry, I'm going to preface this by saying I have the least amount of experience here. I'm just starting out, so obviously I defer to all you guys with much more experience than me, but just kind of based on my experience and my training, it's a really interesting discussion talking about delayed reverse and doing the reverse later on, whether it's as a secondary procedure or after the fracture is consolidated a bit. I've seen it done different ways, different philosophies. I did residency on the East Coast and then fellowship out on the West Coast. If you were to do a reverse, let's say in a delayed setting where the tuberosities are either malunited or they're resorbed a bit, it questions how can you get reliable healing if you were to repair the tuberosities back. However, I've seen it done both ways. In residency, they were really adamant about repairing the tuberosities. There's a lot of talk out there. If you repair it well, you get better external rotation. People are able to, reach the back of their head with forward elevation and external rotation. But I've also seen it done where in fellowship, believe it or not, people would disregard the tuberosities. And I've seen patients do well with that as well. I think, I've only done a couple in practice, but I think to me, sometimes seeing if the tuberosity is a nice big chunk, big piece, I do like to repair it because I think it's also more of like more for stability as well, as opposed to just for function. But it's, it's really interesting trying to see how these patients do in a delayed setting, because at that point you may not be able to get reliable tuberosity healing anyway, and they may do just as well. So it's just interesting.
I mean, it hurts me as a fracture surgeon to hear you throwing away the tuberosities. But anyways, Brianna, you were going to say something. Sorry.
Yeah. Well, also, I mean, just to echo what Robbie asked, I just started in practice. I'm a few months in, and I came from a very shoulder elbow heavy residency where we did a lot of arthroplasty, and the tendons were essentially split, and some did ignore the tuberosities, and others repaired them. And the results, I was shocked the first time I saw it. Anecdotally, were actually not that different based on what I saw. And I remember looking it up and seeing that not repairing the lesser actually didn't seem to, or not repairing the subscap was potentially even associated with lower dislocation rates with reverse, which is quite interesting and a little bit counterintuitive. I think one of the things that I've been thinking about a lot recently, because I've done a bunch of them recently, is, when you're fixing a proximal humerus fracture, it's head split, it's a fracture dislocation, there's something that's sort of, pushing you to want to operate on it. If you want to leave reverse as a good option later, what are the ways that you can sort of least muddy the waters or least increase the risk of that revision surgery while still giving someone a good initial fracture fixation? And so, I tend to use fibular strut allograft in these cases, and I've started reconsidering that, and I'm thinking about moving away from it because now these patients are going to be mine, and I'm going to have to do the revision to the reverse, and it's going to be really, really painful having that fibular strut in there, and I know that. And the question is what people have been using, and so the question number one is, do we know how to best attempt to fix? Because I, like most of us on this panel, I tell patients, I'm a bone fixing doctor, not a bone replacing doctor, first and foremost. I just hate cutting things out and taking away bone stock, putting an implant risk in that represents a peri-implant fracture and a periprosthetic joint infection risk for the remainder of a person's life if I think I can fix something and give them an equivalent result. It just hurts me philosophically. There's nothing to support that as a treatment philosophy except for that. But so, what are the things we can do when we fix these to make the reverse have lower complication rates? Should we have to convert to that down the line? And what are people using instead of fibular strut? I've used femoral head, sort of metaphyseal bone. I've seen different things used. Does anyone have success with something or other recommendations about ways that will make it easier to fix and then convert to reverse?
Great questions, Adrian. Yeah, it sounds like you're eager to answer that because I
have, yeah. So I mean, no, sorry, I rarely put my hand up unless I really want to talk. But so I agree with you. So it's so funny to hear you say that you stopped doing it when they became your patients, right? Because that is the pain of a fibular strut, right? You basically, like put this massive piece of cortex right where you need to like have dull reamers going into. So actually, you mentioned one. So I'm a staunch believer in femoral head allograft. And like, I don't know if you guys know that mushroom technique, where you kind of make a little stalk and like the bulbous mushroom, because it works wonderfully for even like the old osteoporotic patients, because essentially once you do it right, when you put the mushroom graft in the shaft and the head, just like if it's a 4-part, the head just sits on it and you just like pull the tuberosities and they just come like almost like it's like magic. So and then you get really good feedback and in terms of, we're talking about fixing in terms of your screws, and like if everything fails, it's just like regular bone, right? I mean, and I've done a few now where I've had the femoral head allograft in there, and it actually has felt pretty normal, if to be honest with you, right? So so that's my go-to for that. Another thing, we've kind of talked about it too, is I feel like just even in this conversation, there's kind of, as in real life, there's two camps. There's people who like philosophically believe in like bone fixing, and people who philosophically believe in like bone, cutting out and reconstructing. And really, I think what we're talking about, though, especially with this becoming maybe a little more subspecialized, is like what is right for the patient in front of you. Like the reason we have this big toolbox is like we can do all of it, hopefully, right? And then we can provide the patient with informed consent and say, well, here's the pros and cons of this, and here's the pros and cons of this, right? Because we all know in a patient over 65, there are rates of a periprosthetic complication from an ORIF failure, so screw cutout, head collapse, all that kind of stuff is like massively high, and I think like twice as high as somebody who's like under that age group, right? So I mean, sometimes if they're supremely osteoporotic, maybe the discussion is, hey, listen, if you want your your own bone back, we can do this. Here's the failure rate. However, and the bailout is a reverse. However, if you want one surgery that I can pretty much guarantee you from the literature, I can get you 130 degrees of forward elevation, touch top of your head, you can eat, and you can get moving within about 6 weeks or so. That's a reverse, right? And so what do you want, and what is your risk tolerance? So I think the onus is on us to kind of philosophically be both of those people and just give the patients what they need based on informed consent.
I think the thing I found as an interesting takeaway too is just how they felt like one patient population to me initially, but clearly there's just some of these patients are just all across the map, and there are people that we would never offer surgery to at all, it's because they're just so frail and it's not a good option. And then there are people that are kind of in between, and do we jump right to reverse? Or is their bone stock really bad though, and we don't even really want to try to fix it, but you maybe feel more comfortable? And I think that's sort of where the not even just the data helping you with patient selection within those groups as we do more studies and kind of figure out who's best tailored for which, as well as like what's best in your hands for sure, but obviously who also is just set up to succeed based on whatever their medical comorbidities might be. And I think that's, as we've started to look at more of the patients we see as frail too, and getting things like A1Cs and other stuff, and realizing, these people have unmanaged diabetes or COPD and they're actively smoking, and like trying to intervene on some of those in the moment too, even if regardless of which pathway you go down, it's just going to set you up to succeed. And so hopefully, these fracture liaison pathways become more and more abundant, or at the very least, we just as orthopods feel more comfortable managing some of these conditions, because ultimately I think that's going to make anybody's outcome better regardless of what surgery they go down.
That's awesome. I want to be a little careful on time because we have like 2 minutes left. Herman, were you gonna make a comment? Because please, if you do, fire away.
Oh, I just didn't want to take too much time, but I feel like this kind of might summarize these kind of ideas that came up. And one, these are hard fractures to treat. And I think that's what we're learning across all of these studies is a proximal humerus fracture, although many felt that it was in the realm of something we can easily just fix and kind of get that patient on a life. It's not one of those fractures. And I think it behaves a lot differently than, hip fractures and wrist fractures and lots of other common injuries that we treat. And I think that's, what highlights why non-operative management has become, the literature has shown on an average effect. It's probably something we should really highly consider for a lot of these fractures, because on average, we're not great at fixing these things. So I think, we have to consider that even when we talk about all these options. On average, between open reduction, internal fixation, hemiarthroplasty, reverse, non-op management, all the options we've kind of discussed, there's different ways we can perform them, and on average, maybe the most aggressive bone replacing option is the best, because we're not going to have a bunch of these complications we're going to see with these other on average performed operations, where you might need a fibular strut and all these other complex things that might subsequently make the subsequent procedures harder. So I think it just, we need to have these discussions with our patients, as Adrian kind of mentioned as well, and bring these ideas and numbers and options to them, and let them choose and really choose what risks they're going to accept, and how, if they choose an option that we can't necessarily provide in our toolbox, get them to the people who can. So.
Oh, that's perfect. Awesome. We had one last buzzer beater question. So it's going to be a yes, no answer from everyone. So it was, do you have a top age or a lower functional level that you do not offer surgery to? We'll start up. Adrian, you were typing, so why don't you give us an answer? Yes.
No, I actually really like Brianna's answer in the chat box, so I totally agree. So it's physiologic age and based on risk benefits of the patient.
Perfect. Just for those that didn't see what Brianna had typed there. So the short answer is no. Age looks different on everyone, and patients have different goals and risk tolerances. I discuss options and kind of leave the final decision to the patient, which I think, Herman, you were nicely summarizing there with that. Everyone on the panel kind of agree with that sentiment. There's not really a hard cutoff, but more of a discussion point. Perfect. Well, want to be mindful of everyone's time, so I'm just going to load up one quick little thing for us, just to highlight what we have coming up. I want to first thank the panelists because that was an awesome discussion and some really great talks and some great papers to review. So thank you very much for spending the evening with us and taking the time to talk about your research and agreeing to answer questions and talk about this really kind of fascinating, very challenging topic, right? I think if you've taken anything away from the discussion, it's that no one person has all the answers, and probably trying our best to fit the solutions that we have, and we've got some great ones, to the patient is probably the ideal. So again, thank you so much for spending the time. Quick comments, which are basically please tune in for the December 20th journal club. So it'll be similar to this one. We're going to talk about geriatric peritrochanteric fractures, another kind of very topical, very interesting topic to discuss live. So join in for that. Last but not least, this will be recorded, or has been recorded, and will be online within kind of 24 hours. There'll be a link sent out for all the people that registered. So thank you for registering, thank you for attending, and thank you for your questions. You'll see it on YouTube and obviously on the AO North America website. So thanks again. Enjoy the rest of your evening, and much appreciated, everyone.